الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. HIV and the Healthcare Workers by Professor Mahmoud Hani Suleiman. Healthcare workers, especially those who deal with large numbers of HIV-infected patients, have a small but a definite risk of becoming infected with HIV due to the from a patient to healthcare worker reported in 1984. Occupational transmission of HIV reported in most countries. For example, in US between 2006, 57 healthcare workers had documented seroconversions to HIV following occupational exposures. Rules of exposure lead to infection were as follows: 48 percutaneous, either puncture or cut injury, 5 mucocutaneous, 2 both percutaneous and mucocutaneous, and 2 of unknown route. Of 57 healthcare personnel, materials infected them were blood in 49 exposed, lab in 3 concentrated virus, bloody fluid 1 visible bloody fluid, and 4 to an unspecified fluid. To be continued. Occupational category included in these extents 19 laboratory workers, 24 nurses, 6 physicians, 2 surgical technicians, 1 dialysis technician, 1 respiratory therapist, 1 health aide, 1 embalmer or morgue technician, 2 housekeeper and maintenance workers. In addition, at least 140 possible cases of occupationally acquired HIV infections reported among healthcare workers in US. This is the picture in US alone. Number of workers who actually acquired the infection through occupational exposures is not known. Risk of HIV infection following percutaneous exposure to HIV contaminated blood about 0.3%, and after mucous membrane exposure around 0.09%, i.e. 3 times more after mucous membrane exposure. HIV transmission after non-intact skin exposure estimated more risk for mucous membrane exposure. Risk for transmission after exposure to fluids or tissues other than HIV-infected blood also considerably lesser for blood exposure, less than for blood exposure. Risk of infection with a suture needle considerably less than that with blood drawing hollow bore needle. Most cases of healthcare worker seroconversion occur due to needle stick injuries. It's obvious that adhering to standard guidelines for dealing with sharp objects lead to significant decrease in this type of accident. A study showed that 27% of needle stick injuries due to improper disposal of needle. More than half of these were due to recapping needle. 23% occurred during attempts to start an IV line. 22% occurred during blood drawing. 16% associated with IM or SC injection. 12% associated with giving an IV infusion. Clinicians should consider occupational HIV as urgent medical condition. Ensure timely post-exposure management. There must be timely post-exposure management and possible giving post-exposure antiretroviral prophylaxis (PEP). Recommendation on PEP must consider variety of conditions, determine risk of transmission of HIV following occupational exposure. Several factors associated with increased risk of occupational transmission of HIV. These include deep injury, presence of visible blood on instrument will lead to exposure, injury with device that was placed in vein or artery of source patient. Lastly, terminal illness in the source patient. Other important issues in PEP in health care workers include known or suspected pregnancy or breastfeeding, drug-resistant virus, and toxicities of PEP regime. Wound should be cleansed immediately and antiseptic applied. If decision is made to offer PEP, public health guidelines recommend 1. Combination of 2 nucleoside analog reverse transcriptase inhibitors given for 4 weeks for less severe exposure, or combination of 2 nucleoside analog reverse transcriptase inhibitors plus third drug given for 4 weeks for more severe exposures. Most clinicians give the latter regimen in all cases from the beginning when decision is made to treat. Follow-up of exposed workers to improve PEP adherence, monitoring for adverse events, and expert consultation in management of HIV. Health care workers can minimize the risk of occupational HIV by following guidelines which include, these are important: adherence to universal precautions, refraining from direct patient care if the healthcare worker has exudative lesions, disinfecting and sterilizing, reusable devices employed in invasive procedures. The logic of universal precautions is that every specimen should be handled as if it came from someone infected with a blood-borne pathogen. All samples should be double-bagged. Gloves should be worn when drawing blood, and spills should be immediately disinfected with bleach. Trying to put this small but definite risk to healthcare workers in perspective, it is important to point out that it is important to remind you that about 200 health care workers die every year due to occupational hepatitis B infection globally. Tragedy is that these infections, and this is due to HBV, could be greatly decreased by more extended use of hepatitis B virus vaccine. Risk of hepatitis B V infection following needle stick injury from a hepatitis antigen positive patient is much higher than risk of HIV infection. There are multiple examples of needle stick injuries where patient was positive for both HBV, HIV, and HCW, infected only with HBV. That is to say, infection with HBV to healthcare workers is much more higher and important. For this reason, it is advisable, given high prevalence of HBV infection in HIV-infected individuals, that all healthcare workers dealing with HIV-infected patients must be immunized with HBV vaccine. So, all healthcare workers should have PPD check yearly, receive 6 months of isoniazid treatment if PPD converts to positive. In addition, all patients whose diagnosis of TB is entertained should be placed immediately in respiratory isolation pending results of diagnostic evaluation. Emergence of drug-resistant organisms, including drug-resistant TB strains identified in Africa, made TB an increased problem for healthcare workers. This is particularly true for healthcare workers with pre-existing HIV infection. Important for healthcare workers. Important notices for healthcare workers. Post-exposure prophylaxis. When healthcare worker prick himself with needle during patient care without panicking, this is what he need to do. First aid. Immediately wash skin with water and soap and rinse. Do not scrub. Do not use antiseptics or skin washes like bleach, chlorine, alcohol, betadine. If there was a splash on eye, irrigate with water or normal saline. Do not panic. Do not put pricked finger in mouth. Continued important notes for healthcare workers. Do you need PEP for HIV? A significant exposure from a HIV positive person needs to be considered for PEP with 72 hours most of exposure. No lab testing is needed for initiation of PEP. Drugs 2 NRTI AZT plus 3 TC for 28 days. Add a protease inhibitor if drug resistance is likely. HIV testing, 2 tests, one just after exposure and another after 3 to 6 months. Also, check patient's blood for HIV and HB and hepatitis C.